Welcome to the HealthspanMD podcast. Hi, I'm Dr. Hurst. We created HealthspanMD for people who are dissatisfied with healthcare. Common complaints about healthcare include difficult access, poor communication, rushed appointments, disease-focused or sick care with little interest in helping people get or stay healthy, and little to offer beyond a prescription or procedure for optimizing health. This type of healthcare is unacceptable. But most aren't aware that they don't have to accept low-quality health care. HealthspanMD provides exceptional medical care. That means appointments when you need them, time to talk to your doctor, get your questions answered, understand your problems, and get a clear plan to achieving your health goals. But it also means a comprehensive, proactive approach to your health that goes beyond prescriptions and procedures. As a HealthspanMD patient, you will get our expert, physician-led team of doctors, health coaches, dietitians, exercise specialists, mental health, and other health professionals to help you take advantage of your best opportunities to prevent, treat, and even reverse disease. And you may be eligible to have our care model reimbursed by Medicare and some commercial insurance. If you're no longer willing to settle for low-quality health care, schedule an appointment at HealthspanMD to experience healthcare as it should be. So welcome to the HealthsPan podcast, where we talk about building your system to add healthy, strong, mentally sharp years to life. And if you're interested in brain health, you will not want to miss this episode because we have a true expert in brain health. Dr. Dani Cabral, an Ivy League trained, internationally respected Alzheimer's specialist who is board certified not just in neurology, but also psychiatry, with over 15 years of experience in Alzheimer's care and clinical researcher. She is the founder of a great practice, an innovative practice to help people navigate brain health issues called Brain Love. She's here to join us for a conversation about how we can all stay mentally sharp for life. Welcome to the HealthsPan podcast, Dr. Cabral.
Thank you, Dr. Hurst. Thanks for having me.
Oh, I'm just so excited. Like, we've been talking about this for months, and I have just been chomping at the bit to get you on because, this whole topic is one, it's near and dear to my heart because of my interest in preventing heart disease, but also, man, people are interested in this, and it's exciting. Like, an area where there wasn't a lot of hope in the past is just like, it seems like weekly we're hearing exciting news about things that I just really can't wait to dig into this. I was thinking when we were preparing for this podcast, like my history, and, I got interested in preventing heart disease when I was a fellow at Mayo Clinic. But I remember when I, got out my fellowship, I started on staff there, and I started the Heart Health and Performance Program. And, at that time, preventing heart disease was almost borderline alternative medicine. Like, people didn't really believe that you could do it. I was trained that if you got a stent, you needed another one in 3 to 5 years. If you had a bypass, 7 to 10 years later, you'd need another one. I remember my colleagues would introduce me kind of like you introduce that crazy cousin that believes in an alien abduction, like, oh, here's Dr. Hurst. He's our prevention guy, like it was all made up. But, now I, firmly believe, and just from experience, that heart disease is really optional for people. Let me ask you this. Do you think dementia has the potential to be that in the future as well?
100%. It can already be that now, and we have enough data to prove that, to support that. And I want to say that with a caveat that not everyone, not 100%. There's so much we don't know, but we, talking with you about this is so exciting because the things that are going to prevent progressive cognitive changes as we get older are exactly the same as the things that you're doing to protect the heart and the blood vessels. So it's what I'm starting to call multi-disease risk reduction.
Yeah, I had that same epiphany because, I over the years, it's been interesting that people would, come to me, my patients, and they'd say, I'm afraid of heart disease. Yeah, I don't want to have a heart attack, but man, dementia, like that's what I'm really afraid of. That's what I'm really scared of. And so I remember the time when I'm like, okay, well, what does it take to prevent dementia? And I really did a deep dive, had AI and did all the research and things. And I realized it was almost superimposable on what I do to prevent heart disease. It was vascular health, it was metabolic health, it was habits, a lot of the same things with some nuances, some outliers in there as well, but it really is very much the same thing. And I'm intrigued by what you say in that, how optimistic you are right now, because I don't feel like that's really well understood by the general population. In fact, as part of my practice, I'll often do genetic testing whenever I see somebody who has, more artery disease than you would expect from their risk factors. I'll talk to them about doing genetic testing. And if APOE4 comes up, there are some people that are like, nope, I don't want that because I don't want to know. I don't want to know. What would you say to somebody who's wondering out there, like, I don't really want to know what my risk is because I'm afraid there's not going to be anything you can do about it?
Yeah, that's, I feel the need to give a nuanced answer to this because it's not that everyone should just go out and get their APOE4 tested now. So that's the Alzheimer's risk gene, right? And we know that that if you are a carrier of that, it could impact your ability to get long-term care insurance, life insurance, things like that. So if you're still employed, midlife or younger, you need to know about those, caveats. But we are in a totally different world, even just in the last 5 years, let alone 15 years, about what we understand about the role of APOE in the brain and how we can act on it. And we're gaining more data that APOE4 carriers may benefit more from these lifestyle interventions than non-carriers. And so there is so much reason to find this out sooner and to act on it. And I think I'm sure you agree, and from what I've heard from your patients, this is your approach, but mine is always knowledge must lead to action. So I am not going to do an APOE4 test or Alzheimer's biomarkers if we're not going to have a plan to move towards what are we going to do with the results? How are you going to take action in your life precisely for you and what you can do and are willing to do?
Yeah, that so much aligns with how I want to practice as well. And in heart disease, there are a lot of things that we can do that have predictive power that I don't do in my practice. And sometimes patients will come to me with a big list of things that, they've gotten from another provider and say, why don't you do these in your practice? And I say, well, because they're not actionable. Like, if it's not going to change my plan or I can't act on it, I don't see the value of getting that. I should have stepped back on this a little bit. Could you give people a little bit of background on what APOE is? What do you mean by APOE carrier, and maybe what that risk is for Alzheimer's dementia?
Yes, APOE or apolipoprotein. So that's a gene that's involved in cholesterol metabolism. And maybe, Dr. Hurst, you even know more specifics about how it factors into that. And so we all have 2 copies of this that we get, one from each parent. And there's 3 options. There's APOE2, APOE3, or APOE4. And they each carry different risks of future Alzheimer's disease symptoms. So the APOE2 has found to be protective. So if you carry that, you're less likely to develop Alzheimer's symptoms. If you are APOE3, that's an average risk. So it's not like you're definitely going to get it or definitely not going to get it. It's an average risk. And then 4 is the elevated risk. So if you have 1 copy of the 4, you have a 15% higher risk of Alzheimer's symptoms during life. So that's 15%. And if you have 2 copies, it's 35% higher risk of developing symptoms during life, mainly by 75 years old. So it's not like a slam dunk at all. And I've seen people who are 80 who have cognitive impairment, who are APOE44 and don't have Alzheimer's changes in their brain. So they have another reason for their cognitive impairment. And that's an important topic to keep in mind as well. And so it's helpful to know, and it can guide a lot of things that we do, including it plays a role in the risks associated with the new Alzheimer's drugs, the anti-amyloid monoclonal antibodies. If you have a 4/4, you are at higher risk of those. So there's a number of things that we're still learning about that.
Well, maybe just an aside, question aside. With the new MAB drugs, I've read that about the higher risk for the brain bleeding. What is it? I can't remember, ARIA or something is the acronym. Does that mean if somebody's APOE4 carrier that they are not eligible, or it's just a different protocol, or what, or is it something we're still learning about?
Great question. So it depends what country you're in, how they can how they treat people who are APOE4 carriers. So in the US, we can still prescribe to anyone regardless of their APOE status. And so we know that knowing their APOE4, we will counsel them if they are eligible for these medications. And so these are these are heavy duty removers of amyloid plaques from our brains. And so we have to find out we have elevated amyloid and we have cognitive impairment in the early stages, and that would be defined as Alzheimer's disease. And so those with APOE4 portend a higher risk of these microbleeds and swelling from these medications. And so we counsel the families and the patients and inform them, and they can still decide to use these medications. And with them, we catch if these side effects are developing by doing 4 MRIs in the first 6 months of treatment. So we catch it before there's any symptoms, almost always. Now, in some other countries, it's contraindicated. If people are 4/4, they're not permitted to take these medications. But having led at my site the phase 3 trials for both lecanemab and donanemab, having 4/4s in there, I feel that people should have the opportunity to know their risk and to be able to make that decision for themselves.
Yeah, the thing that I think is under-recognized with the APOE4 carriers is they are at higher risk for vascular disease as well. And, I see that a lot from my standpoint, because I see somebody that has more atherosclerosis than you would expect. We do genetic testing and they're APOE4 carrier. And it kind of leads me, I guess it leads me to the next question for you, is that I know we like to put things in very clean buckets, right? Like this is Alzheimer's dementia, and this is Lewy body, and this is vascular. But oftentimes there's an overlap with these things, and they don't fit into clean buckets. Let me, I guess, 2 questions along that. One is, if somebody is an APOE4 carrier, but they do mitigate the vascular risk that they have, they identified early, treated early, they don't have the artery disease, do you think they still are at higher risk of dementia? I mean, is it a purely vascular thing, or is there more complexity to this? And then but then the next step is, what is that overlap? I mean, between this whole protein deposition, amyloid tau, vascular disease, how do you think about that? How do you explain that to your patients?
Yeah, it's quite complex, and I think we have at least some foundational understanding of what's going on here. And so these the vascular pathways and the amyloid centric pathways are deeply interconnected, and so they both promote vascular dysfunction, and that can cause the protein buildup, and that can then worsen the vascular injury. And so we know that people have mixed pathology very frequently. So when we look at brains at autopsy, a large number of them have both vascular disease, significant, and the Alzheimer's changes. And so if we think about it during life, how do we know which of those is actually causing the symptoms, the memory loss and whatnot? So even, I want to mention this too, for people who are older. I always say, when I see people, we do a brain tune-up at BrainLove. And so we look at every possible cause of cognitive impairment, and older people usually have 3 to 7 causes. And those could be, sleep dysfunction, depression, thyroid issues. They're sedentary, routine, they don't have a routine. So even if they have amyloid building up, even if they have vascular disease, right? So we can address all of these things. So I just want to put in a plug, like there's so much we can do to help people feel better, and usually like right away. Now, going back to your important question. So from my understanding, there's 3 key mechanisms that overlap here. So there's this, you've probably heard of the glymphatic system, which is pretty fascinating, right? So we've learned that while the body clears toxins through the lymphatic system, the brain is with something called the glymphatic system. And this has been discovered in the last 10 years or so. And it's a G because of the glial cells are involved. So basically the perivascular or parasites around the blood vessels in the brain, when those get damaged, that creates these gaps and dysfunction. And so our brains can't clear the toxins, which include the amyloid and the tau and inflammatory factors. And so then there's like this perpetuating cycle of worsening damage, worsening protein buildup. And it's like your brain gets more fragile and conducive to both of these things. So that's one thing. And then we know about this entity called cerebral amyloid angiopathy, which some of us are genetically more inclined to have. And so we know that APOE2 carriers are more likely to have cerebral amyloid angiopathy. So that's when there's actually amyloid built up around the blood vessel wall. And so that destabilizes the blood vessel. And that's thought to be one of the main reasons that these Alzheimer's drugs cause these fluid shifts, because when you're sucking that amyloid out, you're destabilizing the blood vessels. And so it's an unfortunate side effect for some people. And then other things we have just, and I'm sure you see a lot of this, and it can be hard to manage, is a chronically low blood pressure or hypoperfusion in our brains, right? So that can happen for a number of reasons as our blood vessels are getting damaged, our little blood vessels, microvessels. And so that leads to the amyloid not getting cleared as efficiently and building up, and then tau and oxidative stress. And so, I mean, I'd love to hear your response to that from your side of things, but there's a lot of overlap.
Very similar to heart disease. I think that's one of the guiding principles that I've realized in building a system that can make heart disease optional, is that first I need to understand what are the root causes for this individual. And I know people can default to one or two, like in heart disease, it's cholesterol or blood pressure. And those are critically important, like no doubt about it. But if we're not paying attention to inflammation, to habits, to, metabolic health, I mean, that's a huge driver for both, dementia and heart disease. We're missing the boat. And so that's part of our initial evaluation, is really understanding those root causes, because without that, our plan is going to be incomplete. We're not going to really understand what those opportunities are. And, and I think that's particularly true for you as well, is that, there are so much complexity around this. There's so many different pathways. And maybe, pointing that out, what I've learned in my practice is that when I've shown people, look, there's other things here that we can address, things that are important in this, it gives them hope. They're then like, oh, okay, wait, I have some agency here. I have the ability to change my outcomes. And so I love that, you're out there advocating for this. And I think that is going to be a message that needs to be heard, because a lot of people are still in that, outdated, frankly, knowledge that, well, the dementia is kind of an inevitable thing. Either you get it or you don't, and there's not much you can do about it. I think that's a system problem, a healthcare system problem, not reality. And you're it's great that you're doing this. I'm going to take a detour here. I want to point out on the screen for anybody that's watching on YouTube, the QR code up there in the upper left corner. That is QR code will take you directly to Dr. Cabral's website, the Brain Love. And, again, great resource. I've sent several patients to her and had just phenomenal experiences there. But I should have started with this, but now I'm going to go to it now. How did you get into building this practice? Like, this is a really cool practice. One, your background's phenomenal. I mean, Ivy League trained, hard to argue with that. But then you're board certified in psychiatry as well. Can you give us a little bit of background on, one, how did you, follow that path, and how did it lead to this practice that you built?
Yeah, I think I love a challenge. And these progressive neurologic diseases, when I was starting out there really weren't many approved treatments. And But when I was pre-med, and I would shadow neurologists seeing people with cognitive impairment and their families, and I'd shadow psychiatrists, I would notice a gap, a different missing piece in each that the other had. So the neurologists would sometimes, they would not address or completely ignore the whole psychosocial, emotional, caregiver, practical, day-to-day, which are, at the end of the day, they're more important, right? So yes, you have to have a good diagnosis. I say the medical and the non-medical, got to have both. That's what BrainLove is doing. But you'd have people crying in the room, and they would just say, well, this is all, there's nothing we can do. See you in 6 months, right? So that is traumatizing, dehumanizing, taking away hope, and setting people into this, like you're talking about, this narrative that it's just like your life is over. So there's a person who's like 65, they're still working, they have mild cognitive impairment, and then suddenly their life is over. And what would happen was they would actually stop doing things that they loved. And it was a lot of mindset at that point, but it's not their fault. It's the world we're living in. There's a lot of stigma. So then when I'd be with a psychiatrist, sometimes they wouldn't really read the MRI or understand the complexities of what was happening in the actual brain, and things like co-pathologies like Lewy body disease, motor changes. So I thought, like, let's put it all together and try to connect the dots and actually link everything. And so when I was in practice at a fantastic specialty memory center, despite having all the bells and whistles, families and people would still feel like they weren't getting what they needed. They didn't know what was going on. They didn't know how to navigate. They were drowning. And so I just decided, I'm just going to try this on my own, try a different approach that to me seems more rational and effective, and thinks of the family as the unit of care. And especially I would just, what I've seen is, like, say you have a couple who's been married for 40 years. When one is going down, the others, they're going down with them. They're tied together. And so equally they can come up together. And so that's how I approach them.
What a great backstory, and what an essential thing. I had to laugh, thinking back to my third year medical student rotations. And I loved neurology and I loved psychiatry. But when you said you loved a challenge, I remember the saying that really made me not want to go into neurology. And it was one of the neurologists says, well, we're kind of a diagnose and audio specialty. And I'm like, yeah, I did, and at least in cardiology, I felt like I had more tools available to me. So I applaud you. You definitely took the path, the harder path in this one, but exciting that the work that you're doing, and you're exactly right. I'm just struck by the similarities between what you did and what I did in our path, because, I was at a great place as well, and I loved my practice there, and I loved medicine, but I kept seeing gaps that I knew I wasn't going to be able to fill in that setting. And so ultimately I'm like, you know what, I'm just going to go out and try to do this on my own. And it was a learning curve for sure. I'm guessing you've had that as well. Another area where dementia's really had a lot in the press recently is about these blood tests for beta amyloid, for tau protein. And, like most things that are new, there's no doubt we're going to misuse them. They're going to be done poorly in some ways. But can you talk a little bit about these protein tests, where you see their role, and maybe a little bit of guidance for clinicians, but also patients, on when are those tests a good idea and when are they not?
Yeah, that's a big question. So these have come onto the scene really quickly. So we went from just being able to detect amyloid in the brain with an advanced PET scan, brain scan, like 15 years ago, to now we have blood tests. And it's really opening up the possibilities. It's very accessible, non-invasive, low cost. And now we have, so p-tau217 itself, through certain high quality assays, is highly accurate to detect amyloid in the brain. So pathologic amyloid buildup, especially in people who have symptoms. So I think one of the most important things is that people know it's not a one size fits all. It's not you do a p-tau 217 in a 5-year-old and a 95-year-old and a positive result is going to mean the same thing, right? It's like very different in the person. It's the clinical context, it's the demographics. And so there's a much more higher accuracy in these older adults. And if someone has cognitive change and they're older and it's abnormal, the p-tau 217, then that is like pretty much a certainty that they are on the Alzheimer's pathway. And so it's opened up the possibility to diagnose Alzheimer's, especially for primary care. And so as a specialist, I typically would use that more as a screener. And if I'm going to do the new Alzheimer's medications that we talked about, which carry potentially, high risks, I personally want the confirmatory tests of the amyloid PET scan, which would be covered by Medicare in that case. Because then we can actually see where the amyloid is building up in the brain. We don't just get this number. Now, this is being highly promoted as potential use to diagnose Alzheimer's in people who are asymptomatic. Now, this is being used out there in the world, and we know that it's not yet it's recommended against using it in this population. Studies have and one was just talked about at the recent big Alzheimer's conference. It was this week in London, that people who have no symptoms, older adults, the average age in this was 69 years old. If they have a high to very high p-tau 217, they have 24% or 38% risk, 5-year risk of going on to develop cognitive changes due to Alzheimer's. So, that's really helpful. And I say some of the big things to consider are counseling. A clinician needs to counsel a person like before they get it, because some people will become anxiety ridden, right? And some people could become suicidal if they're asymptomatic and they're like, say they're still working. Maybe they have kids in high school and they're taking care of their aging parents, and they find out they have elevated amyloid in their brain but no symptoms. What are you going to do with that? And so from what I'm seeing in the real world, there's not a lot of Alzheimer's biomarker counseling and psychological readiness testing. Now, if we know that a person we've assessed it, we know, okay, they're going to take specific actions based on their specific life if it's positive, and they're not going to, fall off a cliff with their mood and anxiety, then this could be beneficial in people who are, it looks like 50 and older. This could be have that potential if you have that clinical support guiding you. Otherwise, people who are younger than that, I would recommend against it. And there's a high likelihood of a false reading, and ultimately, it's going to get better, and in terms of the accuracy in those individuals. But it always goes back to, again, for me, it's like, well, what are you going to do with this? What are the actions you're going to take? And hopefully soon our healthcare system will actually pay for those, quote, lifestyle interventions in the cardiometabolic health support that could decrease the risk later on.
Yeah, when I think back on medical school, a lot of, the joke is half of what you learned in medical school was wrong. You just don't know which half. And there's some truth to that. Maybe, I'm not even sure if it was, half may have been optimistic. But, one of the things that I really remember, striking to me was the whole Bayes theorem, pretest probability. That's just not something that our human brains wrap our heads around very well. That, when you understand when the pretest probability is very low and you get a positive test, and the chances that you actually have that issue is like, single digit percentage or something, it really does change your mindset around things. So, clearly somebody has a family history of dementia. You're not, that's asymptomatic. You're not saying, oh, go get the protein blood test here. But what would you say to somebody who has a family history of dementia? They often are very fear driven because they've seen how it went with their family members, and they're definitively in a not me, if I can choose if I have any choice in this, What would you say to somebody that has a family history of dementia in regard to maybe understanding their risk, but then also like, what can you do about that as well?
Yeah. So I've been thinking long and hard about this, and you were one of the people that inspired me to think about how can we operationalize this for people in the real world, because I'm so happy that brain health is becoming such a hot topic, but it's still not clinically, there's no clinical guidelines for how to address this in asymptomatic individuals. And so BrainLove has developed, and we just put it on our website. So we're going to launch this as a proactive brain health program. And so the components of that are speaking to what you're saying. But I would mention that that we know that people who get diagnosed earlier when they are having changes have often had that family history. So they have personal experience, they've gone through it, and they want to take action sooner. And so people who haven't maybe are slower to get this testing. But so I would go back to that maybe. Where are you? What stage of life are you in? Okay, and so if we think about late adulthood, midlife, or sorry, like late young adults, and then midlife, and then later life. So midlife is really where the action is, right? And I bet that's the same for the work you do. And it's interesting that we don't even have a clear definition of when exactly is midlife, but I say 35 to 60. Now, we know that this big Lancet Commission on Dementia Prevention showed that there's 14 modifiable risk factors that could account for preventing 45% of dementias later on in life. And so most of those are cardiometabolic and lifestyle factors. So in thinking about that and thinking about most of those are impacting us the greatest in midlife. So say you have someone in midlife who's asymptomatic, has a family history. I think it's important to really drill down on their personalized cardiometabolic profile. And I would ask you what the latest and greatest on that is, besides, yes, of course, we want our blood pressure under control. Under 120 seems to be, the most effective for warding off later Alzheimer's and related diseases. Now, lipids is another area that I'm particularly interested in what's happening. And there's so much more we can look at now in that area. And I will share a personal story, which is that, so my father had a significant heart attack at 49 and he survived. But after that, I was in my 20s or something. And I would remember that he would say how his cholesterol was so high and it didn't matter what he did. And until he got on like the smallest dose of a statin, that dropped it, but otherwise nothing changed anything. So then over the years, my cholesterol is always elevated. And I was like, didn't matter what I was doing, right? Running marathons, vegan, whatever, no stress. It was always high. So just recently, I was tested for my APOE and that was elevated. And so I'm 47 3/4. And I was like, you know what? I need to finally go on a statin. And I probably am 10 years late. But I'm just, I'm happy that I did it. And knowing what I know, I haven't been a medication person like many of us who are in this prevention space, but and even as a physician, it feels weird to admit that publicly, but then I just said, I can't deny this, and it's so important to address the lipids. So I'm curious what maybe. Yeah. Can I ask you this and then get to the rest of my answer?
Of course. Yeah.
Yeah. So what do you look at? What would you look at in like someone in their late 30s or 40s that has a family history?
Yeah. Not? So, I think the big news I share with people is that you can't really interpret a cholesterol profile if you don't know their risk. And, I've seen people in their 70s with LDLs of 190 and they have no artery disease. Like CT angiogram, carotid ultrasound, no artery disease. It's not a common thing, but it happens. I've also seen people with really great cholesterol that have aggressive artery disease, and they need treatment for that. So, it really does guide me in my, one, do they need treatment at all? But also, how aggressive is the treatment? In coronary artery disease, I know the data for outcomes are best in people that have ApoB levels less than 35. That's shockingly low to a lot of people, but again, I deal with people that generally have more artery disease than the average population has. And so, I'm looking to be more aggressive because they have a more aggressive form of artery disease. I think your journey through this is very similar to mine. Mine wasn't dementia. Mine was a family history of heart disease, like yours. But I took care of my health through this. Of course, you can imagine I was paying attention to my risk factors. I really had no risk factors outside of the family history. But in my 40s, I'm 12 years older than you are, but I started dabbling with statins. Like, I'd take it for a while and then I'd forget. And then I'd say, oh, I'm achy. It's that darn statin. And then I'd realize later, nah, it wasn't the statin. And I'd go back to it. I was off and on, but last year I finally went and got a CT angiogram with plaque composition and found out I had moderate coronary artery disease. Like, wow. It was a real shock for me. Ultimately, I know how to fix that problem. I just didn't know I needed to fix it in me. But I think that, that's one of the things that really led me away from being in a traditional practice like Mayo was, it is a very reactive mindset. It's well, let's wait till you have the problem and then address it. When it comes to heart disease, that's a disaster. I mean, 25% of people, maybe in some studies up to 50% of people, the first sign they have of heart disease, they die. And so waiting for that to occur, of course, does not make sense. I believe, like you do, though, that the future, we're going to understand that dementia is optional. Like, it's something, it used to be bad luck. Oh, you just had bad genes. You just had, you didn't win the genetic lottery. I think in the future it's going to be you just didn't plan well. You didn't look for this, and we're just gathering more and more tools to understand risk earlier and the effectiveness of those interventions. So I applaud you for your statin decision, and I do want to. I've already have this in mind. I want to do a podcast, you and I, on cholesterol and statins and dementia. I mean, we'll be the top of YouTube on that, because I will tell you, just about every patient that I talk to about a statin, the first thing they'll say is, I don't know. I don't want dementia. I'm concerned about that. Yeah. And, I have to go through the story of, well, actually, if there's any data on statins and dementia, it's less. And so, but you and I, we'll save that for another podcast. I do want to ask you, I'm sorry, going back to your other question. Did you finish what you
so if someone really wants to, get everything, all the information they can to take good action for themselves, and their risk. So besides cardiometabolic health, I'd say lifestyle factors. Are you doing everything you can in terms of physical activity, nutrition, sleep, not drinking too much alcohol, of course, not smoking, and then in terms of, and even like hearing loss, getting that addressed, like that does have a link, and that's a whole other topic of conversation, and even vision loss, getting that addressed. And then genetics. So I say not just knowing your APOE status, but knowing if you have like familial hypercholesterolemia or other things that could impact your cardiovascular health. I think it's really helpful to have a baseline, a really good cognitive assessment, which is a neuropsychological evaluation. And so in our proactive brain health program, we have a focused battery done by a colleague of mine locally, Dr. Mahan, and that's enriched with domains that tend to become abnormal earlier when there's Alzheimer's changes, but they're subtle. So this is going to pick those up. And then knowing, overall your biology. And if you're 50 and older, we are going to be doing the Alzheimer's biomarkers if you choose to. and counseling you on those and what to do with those later, and then following you over time. And so this doesn't exist, really much in the world, right? This approach, but everything that you're doing and the way you're educating people here, like I have found, again, I always just want people to take action and stick with it. And so a generic wellness protocol doesn't really do it for most people. They may just have a blip of like exercising or like getting into strength training, and then they stop unless they really understand like what is that doing for their body and their future.
Yeah, it's a reason why I've added in my practice, we have a role called the HealthspanMD strategist, is somebody who is they're coaches, dietitians, but their background, but their role is that support of executing these things that nobody needs to be taught. Like nobody needs to be taught that exercise is good for you or that eating, nutritious food is good for you. But we need to be reminded. We need to be, supported through that, because, developing those habits on our own is just not easy. And I know I personally have struggled with those habits, until I developed them, and having somebody that has my back, that's, supporting me, holding me accountable for those things has really been essential in me getting my results and my patients getting their results as well. And, I think that it's just so interesting, the similarities between protecting your brain and protecting your heart. I heard this from a neurologist recently on a podcast, and they said, I always say, if it's good for your heart, it's good for your brain. And I'm like, there's some truth to that. In fact, maybe you remember this. It was years ago. One of the neurologic societies came out with their recommendations for preventing, dementia, and it was Life Simple 7 at the time, which is the American Heart Association's 7 things for protecting your heart health. So I think it makes sense, though. In medicine, we tend to get very siloed. The neurologist knows the brain and the nephrologist knows the kidneys, but they all work together, right? Like these are not separate systems. There is a lot of overlap between all of them.
Yeah, and they're all linked by the blood vessels.
Yes.
So, and I think a lot of people we don't talk about that as much, talk about the heart or the brain or the kidneys or the pancreas, and so I have started showing people a picture of the vasculature in the brain and saying, look, your brain is 2% of your body weight, yet 20% of your cardiac output. Yeah. Like it is so metabolically active and so needs that so much. So any perturbations of that, or dysfunction of the blood flow, like makes a huge impact. And that increases as we age, like our optimal window for that gets narrower from my perspective for everything. And so
no doubt about it. Gosh, I can't believe we are already like wrapping up on time. I'm going to ask you now, will you please come back? Like,
oh my gosh, I would love to.
We need to have probably about 10 more conversations about this, even to scratch the surface on all the things that we, that we need to talk about. And people are really interested in this. So I think these are going to be really valuable. But before we go, I do want to say thank you so much for being on. Like, this has been a real, joy for me, but could you share with the audience? I know a lot of people are going to be hearing you on this, and they're going to want to know more about you, your practice, your website. Can you guide people on how they can learn more about you and your practice?
Yes, thank you so much for having me. This has been great. And so come to brainlove.health to check us out. So we are creating a new brain health ecosystem to transform how we think about brain aging, to focus on what's possible. There's so much possible. And so we have services that include focusing on diagnosis and ongoing treatment if you're having symptoms. If you're not, as I mentioned, we have the proactive brain health program. And then we have urgent cognitive navigation for people and families who are going through a lot and maybe have so much stress and overwhelm, they don't know what to do with it. And then we have care partner and family support. So reach out, you can send us a message. I also have a podcast called Resilient Aging Unfiltered. And so, would love to connect.
Oh, well, thank you so much for what you're doing. I mean, this is just in such high demand. I'll share this one last story. I have a a patient of mine who he was going through a very stressful time he was selling his business, which I've never sold a business, but apparently very stressful. Calls me. We've been to, he's been my patient for a long time. And he's like, I think I have dementia. He was just terrified. So I'm like, oh, well, I have this connection at one of the big, places here in Phoenix. I'm like, I'll get you in. And so I set him up, I got, call, hey, I have this really, VIP, really want to get him in. And they're like, oh, sure, we have an appointment. And it was 8 months from now, like they're booked out forever. And then when he finally got there, well, one, he'd sold his business and his dementia had gone away, but
awesome.
But even then it was really still a very reactive approach. Like, yeah, you don't have dementia, go away. Like, when you get dementia, come back. But until then, we don't want anything to do with you. I learned then, like, there is a desperate need for what you're doing. And I just say, no, you're going to have the wildest success for this. So thank you so much for doing this.
Oh, thank you so much. Yeah. Thanks for having me.
And thank you for joining me on this. And I can't wait to have you back. I really do. And, for everybody out there who's intrigued, please go visit Dr. Cabral's site, The Brain Love. Thank you again for being on the podcast. All content created by me and HealthspanMD is for general informational purposes only and is not the practice of medicine. No doctor-patient relationship is formed. The use of this information is at the user's own risk and is not a substitute for professional medical advice, diagnosis, or treatment. Most women don't realize that heart disease, not breast cancer, is their number one killer. And vascular disease often looks very different in women than in men. After menopause, risk rises sharply and symptoms can be subtle: fatigue, shortness of breath, instead of the classic chest pain. And for many women, the first sign of vascular disease isn't a heart attack at all, but a stroke or even dementia. But here's the hopeful truth. With the right care, heart disease is mostly preventable and often reversible. At HealthspanMD, we give women a better path forward. We're a unique practice ideal for women's health because we combine cardiology and internal medicine with expertise in women's health. That means we don't just look at your cholesterol. We look at your hormones, your metabolism, your fitness, your sleep, your bone health. And when hormone replacement therapy is the right choice, and that is a decision unique to each individual, we don't take a one-size-fits-all approach, but we manage it with precision so you can feel your best and protect your long-term health. I'm Dr. Robert Todd Hurst, a board-certified preventive cardiologist. After 20 years at Mayo Clinic, my mission is simple. No woman should ever suffer needlessly from preventable heart and vascular disease again, ever. Click to schedule your personalized heart and women's health assessment today.